I'm Dr. Susanna Vanderpool. I'm a neonatal and pediatric clinical pharmacist, and in this video, I'm going to be talking about apnea of prematurity. So, apnea of prematurity is essentially defined as pauses in breathing for at least 20 seconds. It's also associated with decreases in heart rate, as well as decreases in oxygen saturation. And it's really because of an immature respiratory drive. A common misconception is that it's due to immature lungs, but it's actually in the brainstem where the respiratory drive is. That's what's immature and causing apnea of prematurity. And so risk is really dependent upon gestational age. Our extremely preterm neonates, less than 28 weeks, essentially all of them are going to have apnea of prematurity. By 34 weeks gestational age, you can see the risk is much lower, less than 5%. And so we're going to treat these neonates prophylactically under 34 weeks gestational age. So this is our target population for management. So both prevention and treatment of apnea of prematurity is really going to be done by caffeine citrate. So this is a methylxanthine. You may have heard of older methylxanthines called aminophylline, theophylline. These are a lot less commonly used. Caffeine is really the only one that we use today. It has a lot wider of a therapeutic index and less side effects. We also have better evidence. So this is standard of care. The way that caffeine works is that it has activity on the adenosine receptors. So in utero, adenosine activity is really high because it has a neuroprotective role there. So in preterm neonates, it's still a little bit too active. And the consequence of that is that it causes a decrease in respiratory drive. So caffeine comes in and it blocks the adenosine receptors. This allows for the respiratory drive to be stimulated. So the landmark trials that really put caffeine citrate on the map and establish it as the standard of care are the CAP trials. There are 4 CAP trials. This is one of the only disease states that we have actually really long-term data showing that caffeine continues to be safe and effective. And so I'm going to go through all 4 of these trials. So the first trial showed that caffeine use early in life, started in the first 10 days, decreases bronchopulmonary dysplasia. It also decreases duration of mechanical ventilation. One of the short-term side effects is that it delays weight gain by about 3 weeks, but then the neonates will catch up after a few weeks. The second trial found improved survival without disability at 18 to 21 months. It also showed a decrease in cerebral palsy, as well as decreases in cognitive delay independently. At 3 and 4 trials, this is long-term, essentially safety follow-up at 5 and then 11 years. So the early benefits, we don't really see the consequences of those early benefits anymore, but we know that caffeine used early in life doesn't have any long-term harm. So caffeine is given to all neonates who are born at less than 34 weeks gestational age. We'll continue caffeine until they're at 34 weeks corrected or postmenstrual age. So that's because at this point, the respiratory drive is going to start maturing. So it starts maturing at 34 to 36 weeks, and it fully matures by 37 weeks. So essentially, the other thing that's occurring at 34 weeks is that surfactant production is starting. So again, lung immaturity isn't the cause of apnea prematurity, but surfactant production will help to decrease work of breathing. It's a soapy substance. It'll actually decrease the surface tension of the alveoli and prevent them from sticking together on expiration. So that helps the neonates grow out of apnea prematurity, which is part of why we can stop it at 34 weeks versus waiting until 37 weeks. If the infant is still apneic after 34 weeks, then you want to check your hands. You want to rule out secondary causes of apnea. So H is for hypostates. So this would be decreased blood sugars, hypothermia, as well as hypocalcemia and hypomagnesemia. Next is anemia. So that's the A. N is for neurologic. So this would be like seizures or intraventricular hemorrhage. D is for diseases. So think PDA, chronic lung disease, and infection like sepsis or pneumonia. And then S is structural airway anomalies. So something like laryngomalacia. So these are secondary causes that you want to rule out before continuing caffeine for treatment of apnea. We dose caffeine based on the salt, which is caffeine citrate. So we initiate caffeine with a loading dose of 20 milligrams per kilogram. And we give this loading dose so that we reach a therapeutic level on day 1, so there's no delay. After the loading dose, we start a maintenance dose the following day, which is 5 to 10 milligrams per kilogram daily. So the way that caffeine works is that we want to initiate it early to decrease bronchopulmonary dysplasia as well as decrease duration of mechanical ventilation, right? That's what we found from the CAP trials. Some observational data as well as meta-analyses found that there's additional benefit when caffeine is administered in the first 24 hours of life. So this also decreases the need for PDA treatment and ligation, as well as decreases the incidence of severe IVH. So we want to initiate on day 1 of life per that data. So we give caffeine either IV or enterally. We'll usually start IV, and then once the neonate can tolerate enteral feeds, we can transition to an enteral caffeine. The pharmacokinetics of caffeine are pretty unique. The bioavailability of caffeine is 100%. So the IV dose is equivalent to the oral dose. And so it's a 1-to-1 conversion. So caffeine's therapeutic range is pretty wide, 5 to 25 milligrams per liter. Side effects can start to occur at levels over 30, but toxicity isn't really a concern until we reach levels over 50. So you might suspect a supratherapeutic level if you have consistent, persistent tachycardia, heart rate greater than 180, or emesis, repetitive emesis. So in that case, I would get a level. If it is supratherapeutic, hold the dose for at least 4 days to give it a washout, and then restart your maintenance dose at a lower dose. But otherwise, therapeutic drug monitoring is not routine. About 90% of neonates will have a level in the therapeutic range, and so it's really unnecessary to get levels unless you suspect toxicity. And that's really due to the long half-life of caffeine. So this really helps our levels stay very stable. It's also why we can give it daily, and this is another reason why we can stop caffeine at 34 weeks, because we know it'll still be in the system for multiple weeks after we discontinue it. So caffeine's metabolism is through the CYP1A2 enzyme. However, it's completely absent in neonates, and so caffeine's not getting metabolized at all. So that's why the half-life is so long. At 2 months of age is when production of CYP1A2 kicks in. And so the half-life will decrease to 10 hours, and then eventually to 5 hours, which is the half-life in adults. And so elimination will switch from renal to hepatic once it can be metabolized with CYP1A2. And so after a couple months of treatment, the level can start to fall because of that metabolism kicking in. And so you may have to increase your maintenance dose or give another loading dose to maintain therapeutic levels of caffeine. Thank you so much for watching. If you liked this video, please subscribe and let me know in the comments what topic you'd like me to cover next.